It's 5 o'clock. I'd like to introduce Dr. Arthur Cummings. He's late in the night in Ireland right now in Dublin, so thank you so much for staying up to give us this talk. I met Arthur several years ago. He's been a previous guest of the COS, where he and Sandy had visited in Quebec City. And right away, having personal talks with them, I really realized that this gentleman's got some unique perspective on refractive surgery. He did his medical training in South Africa, in Pretoria, then went on to refractive surgery training in Edinburgh, and is now in private practice in Dublin. But what's really interesting about Dr. Cummings is that he's going to present to us, and he's long talked about the new way, or the new way of thinking about refractive surgery, and also what that means for trainees, what that means for other ophthalmologists, what it means for our role in medicine. He may touch upon the College of Refractive Surgery, which is an effort that's being done to get refractive surgery recognized a bit more. And finally, I think we have a lot of trainees who will be watching this, Dr. Cummings, so I really want to impress upon them how we should be looking at refractive surgery. And with your huge involvement with various refractive surgery societies, ACOS, and with the Refractive Surgery Alliance, I think you've educated many of us as to what to expect, and we look forward to your talk tonight.
Thank you, Kashif. Thank you so much. And thank you to all of you signing in and dialing in. And I hope we can have a chance to discuss afterwards too. Look, I really want this. I know in person it's much easier, but I'd like this to be interactive too. So it's quite long. So at any point, please interrupt, ask questions. I think it'll make it a lot more interesting.
Great, thank you.
I'm going to spend the next while, I've sort of planned for 40 minutes, I was asked to share, looking at how we look at refractive surgery and possibly, just how we can change the perception potentially. So I'm going to start off with some interesting slides. The first one says, are you seeing the slides at the moment?
Yes, we see them.
All right, great. So listen, thank you again for the invitation. So this is from the BBC magazine, and it says, there are more people alive today than have ever died. So the idea behind that statement is to let you know that the world population is growing crazily. Now, if any of you really want to think about it and think about it carefully, you'll realize that that statement's not true. There've been about 107 billion people live on Earth, and we now have 7 billion. So we're sort of at not even 10% of the total population. But nevertheless, what it does, it's a very provocative statement to make you realize that there are a lot of people on Earth at the moment, and the population's growing. Second thing is, by 2050, I just want to get this thing out of the way, sorry. The biggest cause of blindness is going to be macular complications of high myopia. And that's a fact. That's nothing out of line. So by 2050, half of the world's population is going to be myopic, and 10% of them are going to be highly myopic to the point where they start getting complications. So can you imagine, if you think about the current setup with blindness, that suddenly this cause comes in and becomes by far the biggest cause? And then 133 million myopic eyes per year are going to enter the ocular maturity age. So every year for your future careers, 133 million eyes, so 60-something million people, are entering ocular maturity at the age of 18 as myopes. All right, so this talk that I was asked to give is basically on changing the perception of refractive surgery. And this gentleman on the left here is someone who changed my life. I was a retinal surgeon. I did a retinal fellowship, spent a lot of time doing retina, but in South Africa, we all did a lot of cataract and LASIK. We started in sort of 93, 94. And this gentleman was the first person to do it in South Africa. And he really took time to teach all his colleagues. So he taught me LASIK, he taught me ICL. And his name was Michiel Kritzinger, and he tragically passed away in a helicopter accident many, many years ago now. And he has an award named after him at the AAO. So I wanted to thank him for the role he played in my life. These are my financial disclosures. None of these really have an impact. Well, I suppose I use the laser and I use the lenses from some of these companies, but none impact the night stalk. So permanent vision correction, no matter how you do it, I want to speak to you a bit about why we need to think about it differently, why we need change. And you're going to understand this talk an awful lot better if along the way you think about this topic called loss aversion bias. And this is something that says the pain of losses is twice as much as the pleasure of gains. So another way of putting that is, let's take a number that means something to us. 1,000 euros still means a lot to me, but let's call it 500 euro. If I say to one of you, let's play this game, we're going to flick a coin. If it's heads, you give me 500 euro. And if it's tails, I give you 500 euro. Turns out no one wants to play that game. And I said, well, I'll change the rules. If you win, I give you 750 euro. And if I win, you give me 500. And still no one wants to play. But once we get to a point traditionally of 2 to 1, so if you win, I'll give you 1,000. And if I win, you give me 500. Then people start becoming interested. And that is a worldwide psychological mindset that we have, that we are more protective of loss than we are of pursuing gain. So in 1992, I was a final year resident in South Africa and was listening to a meeting of the South African Society of Cataract and Refractive Surgeons. And this photograph was put up on the screen by Professor John Marshall. And he told us this was a human hair that had been lasered. And I looked at this and I couldn't get over it. And I thought, you know something, this is the future. And I want to be part of this. I want to be part of this. It was really a moment that changed things for me. And if you look at magazines now, like The Ophthalmologist, or especially CRST, but there are many now, ophthalmology in industry is definitely giving some kudos to refractive, but that's about where it ends. In academic institutions and amongst our colleagues, there's normally a serious paucity of knowledge about what we do. So this gentleman, his name's Daniel Kahneman. He's a behavioral psychologist, and he won, behavioral economist. He won a Nobel Prize some years ago. He's written some very, very famous books. One of them was Thinking Fast and Thinking Slow. And he coined this term of loss aversion. So in cognitive psychology and decision theory, loss aversion refers to people's tendency to prefer avoiding losses to acquiring equivalent gains. And that's part of what we're facing. So I want to speak just about 6 things during this talk. One of them is the scale of the problem. So let's look at this. So this is from I think it's a Danish scientist who put together this thing called the bandwidth of the senses. And what he did is, if you look at this block, the entire block, we're looking at the square surface. Right in the right-hand corner is taste. And taste operates at a very, very slow pace. Then you look at the bigger yellow block, which is hearing and smell. And if this were an analogy with a computer, this would be operating at 12.5 megabytes per second. It would be equivalent to a hard drive. Then you look at touch, and you see touch is 10 times faster, at 125 megabytes per second. And it's about the speed of a USB key. Then you look at sight, and suddenly you realize that sight is at 100 times hearing and smell, and is like a network. So our brains have dedicated not the landscape, I'll show you that in a second, but the processing power to sight in a way very, very different to any of our other senses. If you look at the amount of the brain dedicated to sight, 30% is sight, but when you look at all the other connections, over 60% of the brain is involved in vision with some way, and it has 15 times the number of neurons for hearing. Now, there's not one of us who doubts the importance of hearing. Hearing and communication is key, obviously. But sight is given 15 times that number. So sight is an amazingly important sense, and it's one that refractive surgeons tend to want to exploit and get the most of it. But sometimes our colleagues aren't always thinking about it. I'm always dumbstruck by the fact that in the hospital I work in with 7 ophthalmologists, I'm the only one who uses torics and the only one who uses multifocals that does things like monovision. It's difficult to understand, but it comes from a place which we'll try and figure out where. So what's the global burden of visual disability? So I'll tell you when I learned SMILE is I had it arranged with a colleague in Egypt, and 2 or 3 days before I went out, his mother-in-law passed away, and he was out of action. He had lots of things to do. So what the company said is, well, hang on a second. We'll speak to one of the other colleagues in Egypt, in Cairo. They found a good friend of mine. He said, yeah, I do SMILE, no problem. Arthur wants to come and do a couple of cases. Yeah, we'll get 10 eyes lined up. And I get there on the same day, do 10 cases that came from nowhere. And all of these cases were women in their 30s, 30 to 40 kind of thing, all -10, -12, that kind of number. And the theory was, well, if you're learning on these patients, even if you don't do a perfect procedure, you're very likely to make things a whole lot better for them. So I was very intrigued by how did they find these patients? Where did they find them? And I was told that these patients live in villages. They refuse to wear spectacles because otherwise they're not going to find a life partner. So they go around walking around with -10 correction, just because if they have a pair of glasses on, they mightn't find a partner. I mean, that's unacceptable. So if you look at the burden of cataracts are the major cause of blindness and visual impairment in developing countries, and more than 90% of the total disability of adjusted life years. And there's very few people today who don't believe that cataracts is a refractive process. And then by the age of 65, over 90% of people have a cataract, and half of the people between 75 and 85 have lost some vision and are, having surgery for cataract. This is in 2010. The numbers look even more stark. There was a very recent one. I didn't update the slide because it says enough. In the world population of almost 7 billion, there are 285 million with visual impairment. And of those with visual impairment, there's a small percentage, 14%, that are blind. So if you look at this block at the bottom left, cataract and uncorrected refractive error are the leading cause of avoidable visual impairment. And unoperated cataract and glaucoma are the leading causes of avoidable blindness. So now looking at visual impairment again, uncorrected refractive error makes up 42% of visual impairment and 33% of cataract. And again, we can correct refractive errors when we do cataract surgery. So you're looking at 75% of visual impairment is due to basically refractive error. And in blindness, it's 51%. And looking at more recent data, 7.3 billion people in the world, 36 million people are blind, 217 have vision impairment. So a lot of people are suffering unnecessarily. And what we also find more recently is 55% of visually impaired people are women. And for most societies, women are the backbone of society. If they're not seeing well, the family's got a problem. So look at what myopia is doing. In the year 2020, where we are now, 33% of the world is myopic. It was 22% in the year 2000. And every decade, it's going up with significant numbers. So by the year 2050, we're looking at more than half of the world's population is myopic. And we saw this on one of the first slides. By 2050, the biggest cause of blindness is going to be macular complications of high myopia. So if we think about vision correction surgery, we can't really do that in a very sustainable way without thinking about myopia prevention. That's got to be part of what we offer as a service. And myopia through the developing world, you can also see as the decades go on, how the percentage is increased and how the amount of high myopia is increasing. So at the moment in 2020, of all the myopes, 5.2% are very high myopes. In the year 2050, of those 1 billion people with high myopia, 1 billion people. And yeah, there you go. So 2050, half of the population have high myopia, of which 10% of the population has myopia, and 10% have a high myopia. Now you think of something like presbyopia. So that sounds simple, just get a pair of reading glasses. It's actually quite debilitating when you are functional, you're whatever you may be, and you haven't got your reading glasses with you and you can't see it close. And these numbers are crazy. At the moment, in 2015, the number of people was 1.27 billion in 2011, and published in 2018. For the year 2015, almost 2 billion people cannot see up close. And so if you just think about the economics of vision correction and vision impairment, if you get spectacles in a country like Canada or Europe, you're going to be saving minimum 16,000 euro. So the cost of spectacles and contact lenses until you're in your 40s is about 16,000 euro. Once you start getting into the presbyopia years, over that lifespan, you're looking at probably saving close to 40,000 euro by having vision correction. And you have decreased risk. We know from papers by Frank Price that there's lower risk in vision correction surgery than there is in contact lens wear. Then you have all the other benefits of lifestyle, convenience, occupational fitness. So in the developing world, between 2/3 and 3/4 of people go without refractive correction. There are many reasons. People lose their glasses are stolen. They often sell their glasses. They sell their glasses for food. And you can imagine if you start giving people who don't have visual acuity at a young age, and you provide them with vision, that they can own their vision and have it for a lifetime, you're going to completely change their trajectory in life. And the economic upside is almost immeasurable. So the next thing I want to speak about a little bit, why refractive is different to medicine in general, is this digital tsunami. So tsunami, we all know what a tsunami means. I've got a whole theme about waves tonight, but a tsunami is when something just arrives in overwhelming quantities and amounts. And so all our records are digital, our refractions we can follow. We had a conference recently, about a couple of years ago, where the RSA had one of the speakers on a robot. So there's an image, there's a voice, she was standing in front of the mic, and the robot could move around. She sat on panels. So yeah, really amazing how this space is digitizing and what we can do. So currently, ophthalmology is one of the most data-heavy medical specialties. We know all the roles where digitization plays a role. And we even have areas now where artificial intelligence is learning to interpret OCT data more accurately than what seasoned retinal specialists can do. And if you Google data overload in medicine, you'll get this massive overload of data. There's just too much data currently available. And there are many articles that appear all over the place on making sense of data overload. So much of our field is digitized now, and so it generates data, but how we deal with this data is what becomes the burden. And another area that's digitized is just thinking about the way we use historic RLs, so manual marking or digital marking. And when these are working well, then using it digitally is just a more fail-safe way. Not that manual doesn't work. For those of you who are doing refractive surgery, the way that these devices can collect data from the diagnostics and then share the data between the different lasers is phenomenal. It gives a lot of power, and decisions that normally would have taken absolutely ages are now made almost on the fly with a lot of power. So in refractive, we are a lot like the gourmet chefs of ophthalmology. So the chef needs to choose well-grown ingredients, needs to choose ingredients that are appropriate for what they want to prepare. They then prepare it with expertise and with some love, and then they present it to the customer in a pleasing, functional way. If you think about refractive, it's very, very much the same. So the patient coming in saying, I want to see better, is our raw material. We then have to gather data across the board of everything we need to make the right decision. What's the best procedure? And can we do it safely? We then process that with our skills, and our skills today are based on things like nomograms and all sorts of additional help from the wisdom of the crowd. And then we present the patient what we believe is the best treatment for their outcome. And so now that our fields are getting so big, these big fields require better data. So why do you need sanitation of data? So this all looks very, very good, but if you in your data get some garbage, you're going to have an unhappy outcome. So yesterday we had the time, when I started in refractive in '94, we had the time where we were seeing few patients per week, had a lot of time to go and think about things very carefully. The demand was different. Today we're a bit like this. So instead of going to go and pick it, we have a device that comes in, looks at the sizing, and does some of this work for us, that we don't have to do it manually ourselves. But tomorrow looks different. Tomorrow looks so different that when these things come in, the devices are actually doing the sorting for us. So when we start getting artificial intelligence involved, it's going to help us make better decisions. And one of the things we need to do, if we want to see refractive surgery grow, we've got to make sure that we have trained refractive surgeons that can produce great results at scale. With refractive surgery, and you'll understand more as we go through loss of vision, we can't be having cases that don't turn out well. We've got to be turning out great cases on a consistent basis. This is going to help. This is another space where digitalization is filling in between patients and machines, between patients and physicians, and between physicians and devices. And there are many, many examples of technology that fits on these axes. We're not going to speak about those much tonight. So the digital future is assimilating the data, making better decisions, making more difficult decisions simpler, making more data-driven decisions, and then also making more personalized decisions, much more than we could in the past. So now the manpower challenge. This is a part that's really a big challenge for us. And the manpower challenge goes down to this, first of all, a huge shortage of ophthalmologists across the globe. There are just too few ophthalmologists. There are obviously some areas of the world we sort of feel there are too many, but globally, given the patient needs and demographics, there are too few ophthalmologists. There then also is this very serious shortage of refractive fellowships. There are a good few in the US, maybe 6 or 7 that people believe are good fellowships. The rest aren't really dedicated refractive fellowships. There are a couple in Canada, a couple in Australia maybe, but that's almost where it ends. There are very, very few. Kashif, I was so taken aback when I was at the CSO a little while ago, and I spoke to some young fellows who said, you know something, I want to do refractive. It's what I really want to do, but I couldn't tell anyone that. I had to tell someone I'm going to do a corneal fellowship, but what I'm really doing is preparing for refractive. And that's ridiculous. It's absolutely crazy that we've got to make excuses for wanting to help people see better. It just doesn't make sense. Now, here's where things start getting very interesting. Patients in the refractive space are mostly self-pay. They pay out of their own pockets with their own money. And that changes the game in a very big way. And it's a mindset that we need to change. Or that we need to not change. We need to change the way we think about it. And then teaching hospitals typically don't offer refractive surgery. And then young doctors are not exposed to refractive surgery in their training. So they have very little knowledge of the field. And there's an interesting perception of refractive surgeons. I'm sure you've all heard this before. There are minimal skills required. It's just a gap filler between jobs. It's not real surgery. It's money driven. And refractive surgery is really just a small side dish on the plate of ophthalmology. For those who are practicing refractive surgery, though, they'll have a bit of a different view on it. They know how many people have told them this has been life-changing. It's enhanced my life. It's changed the opportunities that have come my way. And it's very much real-world problems solved by real doctors. It's very different. I did a retinal fellowship. A retinal surgeon used to do a lot of macular holes. And when I did my first LASIK, I was a lot more nervous about that LASIK. And why would that be? Well, the reason was because the patient you're treating has good vision with their glasses or contact lenses. And so there's zero error there's zero place for an error. If you get an error, it's a much more difficult thing to deal with. But someone who comes in with a problem, all we're trying to restore is what happened naturally. And if you don't, it's taken up in a better way than treating a healthy eye and picking up a problem. So a couple of years ago, maybe it was last year, it feels like a couple of years ago, I did a survey for a talk at ACOS in Europe. And I asked a bunch of people how they were taught. And for the group in the room, and it's mostly a lot of people with experience in cataract and refractive, 32 said they had some form of fellowship training, and 68% were self-taught. And I asked them and said, how do you think we'd like to treat young people now? Do you think it should be the same thing that you teach yourself? And the massive majority said, no, we should do some level of formal training and something else perhaps. But no one said go and learn yourself. And the other included things like this course that Jorge Elio provides, it's online, or the one that Ulster University do, it's also online. So you can go and do these courses that are distant learning courses that are pretty good at getting you up to speed. Some interesting comments that came from that was a number of people working with local universities were trying to establish formal training programs. One of them was in Canada. Shiraz Daya was saying, there is no need for new surgeons to learn the hard way. Why should they? We don't have the luxury, for lack of a better term, to go and learn on. We don't want to learn on people. We want to, when we start doing the surgery, we want to be skilled surgeons already. So we need to have good fellowships, good training. I love this comment. Renato Ambrosio said, I see a foremost aspect of education about refractive surgery is to the ophthalmologist that does not do refractive procedures. One of our major problems, we always try and figure the optometrists don't like refractive surgery. Our bigger problem is ophthalmologists don't get it. And when patients from other ophthalmologists suggest they're thinking about refractive, the ophthalmologist often says, yeah, I wouldn't do that. Dan Reinstein was saying there should be a minimum of 2 years training after a corneal fellowship. And Weng Zhang, who's the head of the eye group in China, it's the biggest hospital group, was thinking it should be part of ophthalmology training. I think we all agree with that, but it's just not, it's not going to happen. And then Dan Dury, who's probably the father of refractive training in the US, says he totally supports this idea of a college of refractive surgery. It'll probably take a little while to get off the ground, but we're certainly working at making it happen. So what are the scenarios for training? Well, the one is we just continue as we are, and if you're lucky, you find a fellowship where you get some sort of training. Otherwise, you go a different route. You try and include it in formal training at medical school, which is pretty unlikely. Or we take it into our own hands. And by that, we mean organizations like the RSA, the Refractive Surgery Alliance, decide we want refractive surgery to grow. There is no need that in this day and age that refractive surgery is not the primary vision correction mode. There are lots of ways we can make it work. And I think that's the way we prefer, that we make this work. All right, refractive collaboration. Just going to say a few words about this. So Kashif, you actually mentioned this earlier. CRST has been really good at getting things out there and publishing a lot about refractive, about ways of running practices. And it's been a very, very nice channel to share ideas. So this is one, I think this was CRST, where they're allowed to talk like, a topic like this you won't get published in many other places. Is it time for refractive to become its own specialty? And I think what I'm going to do in the rest of the talk is maybe run some of those ideas past you and just plant the seed for those of you who haven't thought about it yet. And then ACOS has been another amazing organization. In fact, I've just mentioned that. But they're mostly about innovation, education, and advocacy. But what's so fantastic about them is it's physicians, the industry, and the funders that are together. And it's amazing how industry and funders, how they see the value of refractive. And I'll get back to that in a moment. And then the RSA is a group called the Refractive Surgery Alliance. It's about 400 people now that are they're all refractive surgeons. It's a very, very good organization to belong to. They've got so many things going on at the moment with collaborative care. They've got a resident training program that's free to residents. If you're not aware of it, it's something you should share with your residents. They're doing sort of 15 talks, I think. They're mostly at 9 p.m. Eastern. And the program is really strong. And then they record them too on Zoom, and you can watch them at your leisure afterwards. But just some of the reasons. It's the only global organization with the expressed mission of bringing the benefits of refractive surgery to more people. And the main strategy is collaboration. And it's simply by working together, sharing ideas. There's a business focus. We'll talk about this in a moment, but you can't run a refractive clinic without some kind of business skill. Physician leadership is a very important part of driving refractive surgery. They're very unique meetings. They're absolutely unique. There's nothing like them. It's all focused about growing refractive and making it more equitable. There's a forum which is very, very widely used where you can discuss anything. There's so many threads on the forum. There are economies of scale. So the RSA would often bring think about the HD analyzer for argument's sake, and ask who's interested, and the next thing you know, 50 people are, and then suddenly 50 people have a different buying power to someone buying it alone. So you can get good deals on prices. There's good visibility. If I need to send the patient to someone in Australia, I can look at who the RSA colleague is and get it to someone who's a refractive specialist. The cross-generation exposure is phenomenal. There's people even older than me, and then there's young people involved. So it's a really good group of sharing, and the ideas come from everywhere. The fantastic educational opportunities, and there's very good value for full members. It's $800 per year, and you don't pay for any meeting. And then for residents, it's mostly free. It's really good value. So if you're interested in growing refractive surgery, join the RSA. These are some of the meetings they had. Like, this year's been a bit different. We've had many, all of them virtual. During the course of a year, there's a lot of activities and all around the same thing. And then we attend a whole lot of meetings. This was the World Ophthalmology Conference a few years ago, and the Refractive Alliance is getting place, a space on the podium. And then we do things called premier showcases, where you go to clinics that are really at the cutting edge of something, and you spend 3 days with them, and you see how they're doing things. You spend time analyzing their practice, and they then give you problems that they're having currently in their local environment, and then the group collectively think about ways of overcoming it. So it's really good. This was a visit to the Zaldivars, and they are leading the world in many aspects, but in telemedicine, they certainly are. They've got an amazing show. Right, so what are some of the developments in refractive surgery? I'm going to share these very, very quickly, but this is just to show you that this is a space that's moving all the time. Ray tracing LASIK, allografts for presbyopia, a device that tells you what lens to implant for the patient, what lens design, and then something called refractive indexing. So ray tracing LASIK, I think you've seen this before. I'm going to go through this really quickly. But instead of using Goldstrand's model, whenever you do a treatment, on an eye, no matter how good your diagnostics were, is when you put the treatment on the eye, the laser still thinks you're treating Goldstrand's model. And with ray tracing, what you're doing is, thanks to biometry and knowing exactly where the lens is, you can actually create a virtual eye model that you put in place. And then when you look at the ablation you're planning, you put a wavefront in instead of the refraction. Instead of having the arbitrary 43 diopters, you've actually got a pentacam on the front and back surface. And instead of disregarding the lens, the biometer actually shows you where the lens is. And when you have all of that information, the axial length, you know where the lens is, you've got a wavefront, you can then in fact construct the lens. So you can reconstruct the lens using these 2 points, and now with the virtual eye. And then you can plan your treatment on the virtual eye, and then ray trace and see how you can change the treatment on the corneal surface to make the convergence even better on the retina. And the results have been spectacular. So something like wavefront, you're not looking at all the parameters of the cornea, you're not looking at axial length, and what you're doing with ray tracing is reducing these assumptions and simply making it a more accurate procedure. So what it does is it gives you this remarkably simple acquisition of data, and then with huge processing power, you're doing the most customizable procedure possible on an eye. Then it also includes things like the biomechanical response and epithelial healing. And we did a trial a few years ago. The results were spectacular. And we've never, in our experience, got results that were equal to FDA. And you could see here that with ray tracing in the group of -4 to -7, we were outperforming FDA outcomes for 2020. And in the group of higher than -7, we were remaining in the 90% range, where on the wavefront optimized wavelight Allegretto trial, it was at 70%. So the moment you start going into the high myopes, we start losing predictability, not with ray tracing. And on the safety front, in my series, I think I had 60-something eyes in my group, none lost vision, and the huge majority gained 1 or 2 lines. So no lost lines and a lot of eyes gaining lines. So ray tracing is something that's coming, and I think it's something that will help us grow LASIK. And the nice thing about this is when we do things like Contura or these custom treatments, is they do very well in the hands of people who've been doing it for a long time and are skilled at doing it and experienced with doing it. But if you start doing it from the start, you don't understand everything you're doing, you can often end up getting results that are unwanted. The beauty of ray tracing is whether you've done 50,000 procedures or 50, you should get the same outcome, because you're both using the same tool to design the treatment. So it's been launched in Europe this year. It was a bit messed up with COVID, and it's now in a one device called the sitemap. 10 years ago with the initial trial with 3 separate devices, but it's a super addition to our armamentarium. This is something very nice. I don't know if any of you use the Raindrop. It's similar to Raindrop, except it has no issues with biocompatibility because it's corneal tissue. So it's based on the principles of epikeratoplasty that's got a 50-year history. And thanks to all of these issues, improvements in the lasers, in ethical tissue sourcing and metrology, being able to measure a tiny piece of cornea you've cut, and you can measure the power, those types of things has led to the ability to produce very high precision, repeatable sterile lenticles from this donor corneal tissue. And so now what happens is when you do a presbyope and emmetrope, you treat one eye only. And what you do is you do a LASIK flap, and over the light constricted pupil, you place the inlay. It's in that little blob of water, and you simply drive the water. While it's wet, you can position it into position, and then it starts drying, and then it won't move. And once it's in position, you put the flap back. So amazingly, it's completely reversible. If you don't like the results, you take it out. But it turns out patients love the results. So it gives you, when the pupil constricts, you can see the impact on a Scheimpflug early on. Later on, you don't see it because it's Scheimpflug's based on scatter, and you just don't see these after 6 months. But you always see the little bump on placido disc. And on a wavefront, you can clearly see how the central part of the wavefront has this myopia, while the rest of the pupil is untouched. So you typically end up with your distance vision at 20, 25, somewhere over there in the treated eye. Binocularly, you don't notice if there's a change, and reading is typically very good. And on tangential maps, because you can't see these inlays once they're in the eye, a tangential map can show you whether you positioned it properly. Right. So far working really well. The study's completed. The company are now trying to raise capital to take it further. But this is something we really want to see in the commercial world. Viveo is a device. I see I'm running out of time, and I really want to get to the part about surgery. But Viveo is a device that you wear, and it generates a defocus curve for you. And then what you do once you've got the defocus curve, here's a new thing for those of you who haven't seen this. This has happened in the last few months. I'm sorry. You now have the data that you've got from your patient's defocus curve, and you're now going to match it against IOLs. So when you put the data into what's called the lifestyle match index, it first defaults to its generic monofocal. So it's correcting both eyes for distance. And it's telling you in this particular patient, if you do that, they'll be out of glasses for 43% of the day. But this period, this over here, intermediate and near, they're going to be wearing glasses. So you get a very good idea what you're going to do. It then automatically goes and does a ranking like Google would of what lens, and all the lenses you have is going to give you a best option. So you're doing something like the Vivity with an offset of 1 diopter, you're getting a huge increase in capacity. If you do it at 0.75, you can see exactly what the effect is. So you can now really go and speak to your patient and say, the lens we've chosen for you, this is what I expect. So if we put a PanOptix in for you, I expect you can have a very, very good range of vision. What you're going to have, though, is you're going to be slightly weaker than 20/25, exactly at 1 meter. But in your life, you're not doing much at a meter. You're not going to even notice it. You're going to move slightly closer or slightly further away. So you're making decisions based on data. You can even see how monovision compares. And so that helps patients a lot when they're making decisions about private pay costs, that they can see how a trifocal compares to monovision for them. Right, and I think the last, clearer vision, I might just give a skip because I want to get to the crux of this thing. I don't want to go in too long. But clearer vision is just about refractive indexing. So the crazy thing here is you can change the power of a contact lens, of the cornea, or of an IOL that's been already implanted, without changing the shape or the thickness. All you're doing is changing the refractive power, and that's got an incredible power. So yeah, so it's crazy. So let's look at things that are inevitable. So whether you like them or not, electric cars are coming, and in 20 years' time, they'll dominate. I'm quite sure about that. And the same for renewable energy. Another thing that's happening is we're living longer. So these are things that are happening. And I think something that is inevitable, I don't know when it's going to happen, but at some point, refractive surgery will be its own specialty for the reasons I want to share with you. And at some point, when you have a problem with your vision, the first thing people are going to be thinking about is correcting it, as opposed to giving you a prosthetic device to correct it. So this is thanks to the RSA. A lot of this comes from the collaborative thinking we've had. So first of all, authentic refractive surgeons, they don't fly in and fly out. They don't do medical tourism. They don't do a LASIK every now and then to earn some money for the weekend. You wouldn't do that if you were a cataract surgeon, not a cataract surgeon, a retinal surgeon or a glaucoma surgeon. I don't every now and then just do a macular hole for fun. You know, it's refractive surgeons should have a respect for what they're doing and do it as well as they possibly can. And so this heuristic called the availability heuristic, you know what you hear and what you see from your coverage in your news and your social media feeds. Meanwhile, there's a different story of what's actually happening. You just see a part of it. And it looks very much like there's a big area of vision correction surgery, and our colleagues know a very small part of it and aren't learning anything more about it. So it's not easy to change the world, and I'm going to invite you to see if we can try and collectively do this. So this process of evolution, where at some point we dump our glasses, does everyone understand this? Well, elite sportsmen do, the armed services do, first responders do. All these people get it. They have it done because they know what the value is of owning your vision. And so do refractive surgeons. So I'm sure you've seen this article before, but this was through the RSA. But refractive surgeons are five times more likely to have refractive surgery than the general population. And currently, 65% of refractive surgeons have had refractive surgery. There's no other discipline where people have adopted their own services as well as refractive surgeons have. And it's because it works. It's got real value. My entire family's had it done. My wife, myself, my kids. So we certainly understand the value. We understand the economic sense. There's a huge cost saving over time. This is a slide I want to share with you. Is refractive surgery is the concept car of ophthalmology. Without refractive surgery, do you think our IOLs would be where they are now? Do you think we'd be chasing emmetropia the way we are now? These thoughts of aberrations, of toricity, of measuring, of digitalization, they start in refractive surgery. Refractive surgery is a very important part of driving our field forward and giving patients better outcomes. I love the fact that a company like Alcon, I'm involved with Alcon and I consult with them, but I love the fact that such a large company says, our new standalone company, our logo is see brilliantly. Isn't that what it's about? We've seen the brain dedicates all of its time and energy to sight, and we want to help people see brilliantly. So why, if your teeth look like this, don't you go through life like this? These teeth work, but no, we don't. As soon as we notice the teeth aren't looking good, we pay a prosthodontist a lot more than we pay ophthalmologists to fix the teeth. What about someone who's broken a leg? Why don't we use external fixation? It works. But no, we rather go to an orthopedic surgeon to fix it and correct the problem internally, intrinsically. Yet glasses, they break, we lose contact lenses, we get infections, but we still figure that they're the way to go. So refractive surgery is an independent specialty. Is the day before something is a breakthrough, it's considered crazy. But yes, sharing some crazy ideas. So the College of Refractive Surgery, which is well underway, we want to establish it this year. 2020 is a very good year for so many reasons to establish this. It's a big step, but it's not so new because people have done this before us. Plastic and Reconstructive have done this before us. And the American Board of Plastic Surgeons was established 80 years ago. They broke away from general medicine. There are currently 7,000 people who've been through the program of accreditation. Of course, there are people who do plastic surgery without going through that accreditation, but at least as the public know, here's a group who have gone the extra mile to really make sure they're okay. Here's their mission: to promote the field, to practice ethically, safely. They want to maintain high standards, and the parallels between plastic and cosmetic surgery, especially in refractive, are striking. So how is refractive surgery different to general ophthalmology? So let's look at just these few things. Number one, it's performance-based. It's not disease-based. And the standards for excellence are consequentially far higher. If you think about insurance, we all take insurance. If someone's car gets stolen, collectively we replace it. Same with housebreaking. If your cataract flares up or you get glaucoma, your insurance covers it. Refractive surgery, you're paying out of your pocket. You're deciding, I want to get rid of these glasses. I want to see better. I want to function better. So it's performance-based. It's direct pay services. We've got to learn how to deal with these patients whose expectations are through the roof. It's rapidly evolving. You're going to spend a lot of time and energy staying abreast of things. And because you need a high volume to make the costs work, so you've got to have a very efficient system. And then refractive surgery can only deliver on a big scale if we start delivering perfect results globally, not just in certain centers. And why we think it should become a separate specialty is not a divorce. It's not a divorce whatsoever. You can't really do refractive surgery without having done ophthalmology. So you need the basics of that. But to expand to this space that's all performance-based and where we don't get enough training, we need to get a specialized training in it. So I'm not going to, this is going to take too long. I want to go to things that are more important. So physician education for refractive surgery is massive. And that's why we belong to so many associations. And that's why the RSA specifically, that's dedicated to refractive, is so valuable. I mean, you can get a lot of understanding and fellowship from colleagues. A lot of meetings are dedicating time. It's not just book learning. This is the thing you've got to immerse yourself in to understand it well. And the need for refractive surgery evolves through a lifetime, both the surgeon's lifetime as well as the patient's lifetime. We see 18-year-olds. In fact, we see 12-year-olds where we're trying to make sure there's no keratoconus and address that if there is. We're trying to stop myopia. And then once you reach ocular maturity, you start thinking about how you can address this. And you see patients who come in for the first time ever seeking refractive surgery in their 60s. So there's techniques have evolved, technologies evolved, and we've got to be able to make the right decision for the right person at the right time. Capital equipment requirements can be daunting, and that's why you need some understanding of business. Most of this is not done publicly. It's done in private practices. So the cost can run into millions, and it's often a hurdle for doctors saying, I'm not going to do it. And then they rather land up working for someone and in a big chain maybe, and not getting the real patient satisfaction they should be, where they're taking ownership of it. So I think I've sort of covered this idea enough, that this is a space that requires some entrepreneurship. From a patient perspective, the patient needs to be happy with the results. Whether they're 20/20 or not, it's almost immaterial. It's their definition of happy. So they judge us against what they imagine they should have got. And rising expectations in vision correction have spilled into cataract surgery. So we know now that our outcomes in cataract surgery are becoming more important. And very few specialties require greater care of the time-honored doctor-patient relationship than refractive surgery. Now, isn't that a crazy comment? Just something which is deemed to be, just do it on the weekend if you want. And I'm telling you, it's one of these specialties that is going to test your doctor-patient relationship more than any other one. We're not sharing loss of life with people, but we are speaking about things that are really important to them, where we don't want to have any complications. So the 7 core competencies for a significant area of medicine to evolve into a medical specialty are professionalism, patient care, procedural skills, medical knowledge, practice-based learning and improvement, interpersonal and communication skills, and systems-based practice. And if you can think of one off the top of your head now that's more qualified than refractive surgery, please let me know when we have the chat afterwards. So recapping the thought process is refractive surgery relies on excellent ophthalmic skills. In that respect, our ophthalmic experience is our foundation for refractive surgery, but it's so different because our focus is on function rather than pathology. And so we need to put practices in place that allow this to happen in a successful way. We've been meeting patients' demands. This may explain why many of our non-refractive colleagues view us as foreign. And combating pathology is a fight against loss, where refractive surgery is a pursuit for gain. And as I said to you earlier, with the loss aversion complex, is valuing loss over gain permeates much of humanity. Not only what we're doing, and it's part of human nature. So look at this guy whose shares are going up and up and up, and that he just takes in his stride, and then one day they go down a fraction and he's freaking out. And we see this all the time. So a primary goal of disease-based ophthalmology is to avoid loss, stop the decline of cataract line and slow glaucoma, prevent diabetic retinopathy. And the results have been amazing. I'm super proud of our colleagues. They've done great work, but it's still based on this insurance risk. If you look at the people we're helping currently in ophthalmology more than anyone, cataract, 65 years of age, glaucoma, 65, AMD, 65 plus. This comes from a colleague in Canada. If you treat every cataract you did with a presbyopic correcting IOL, the cost of falling in the US is $50 billion, only to the insurers, no one else. $50 billion a year. And if you put in a multifocal IOL and you reduce the risk of falling by 11% by eliminating the varifocal, that's a massive benefit to the patient. And this saving of $4 billion a year by doing this includes the cost of the multifocal IOL. Now, of course, I'm not advocating for putting a multifocal IOL into every patient. But what I'm saying is, with every single patient, we should be doing our best to get them the best possible refractive outcome for their needs and their budget. So some of our colleagues believe that we are wasting our skills with refractive and feel that improving the quality of life, I feel that improving the quality of life is a very worthy pursuit, and refractive surgery improves the quality of life every waking minute. Once we've treated that patient, they own their vision. And benefits are seen in lifestyle, convenience, occupational fitness, personal economics, safety, appearance. So we create value and we pursue gain. I think I am very, very close to my time being up. So let me just go to the end rather. So the key messages are overwhelmingly positive for refractive. We are the agents of change. No one else is going to do this for us. So we need physician leadership to maintain the quality. And I think, I don't know if it'll happen in my time, but if you see what your phone and my phone can do, and we're having a meeting across the Atlantic, it's almost real time. How can it be that in this day and age, we can have the majority of people who can't see not being able to see because they don't have glasses? And there are ways that we can make this happen. And at some point, refractive surgery will become the default method, just like your braces. So humanity lived without glasses until the 13th century, when people started thinking about spectacles and glass for distance correction. We now have the potential on a mass scale to eliminate this congenital defect. It's a strong term. So I'm telling you that refractive errors are congenital defects. So ophthalmology currently, refractive surgery sits somewhere inside of ophthalmology. What makes a lot more sense is for it to be a separate subspecialty. Ophthalmology at the board's level has not broken down into anything yet. But retina is so different to refractive and to glaucoma, they need to be their own specialties. So one of the thoughts we have, and this is where the College of Refractive Surgery comes from, is imagine a place where you can go and learn more about refractive surgery. You can then pick multiple points on the globe where people are doing things. You've heard they're doing SMILE at a cutting edge. They're doing ICL at a very good level. You can go and visit them and see what they're doing. You can come into centers like ours for LASIK potentially. And you can then go to a place where the Refractive Surgery Alliance is working in a fellowship program and now bringing those benefits of refractive surgery to third world situations, changing people's lives, in the process, training surgeons and allowing older surgeons to mentor people. You know, we've seen the Himalayan cataract project, we've seen the Indian cataract camps. There's no reason why we can't do the same thing for refractive, and everybody wins in that model. So what will it take? We would have to slow the development of myopia. We need to target younger patients. The earlier you treat them, the longer they get the benefits. We need systems in place that can do this at scale. We need dedicated, focused leadership. And we need to attract investment. This will cost money to get this in place. But the main thing that it will take is physician leadership. And that's you. That's many of you. I'm so delighted. I don't know if any of you know someone called Jack Kane. Jack Kane today is a final year resident in Australia. It's a 4-year program. He's in his 4th year. He's got the most accurate IOL formula on the globe for myopia, for hyperopia, for long, short eyes, and for keratoconus. It's a free website. You put your data in, and Graham Barrett, Warren Hill will all tell you, Doug Koch will tell you, that is the most accurate formula now. He wants to dedicate his life to refractive surgery. And we need people like him to change the tone of the brightest are going for this field because they believe it's got a value. So I believe there's a tsunami coming. Have a wetsuit, whether you're into refractive or not, it's going to become more and more part of our daily digest. And we're not going to be able to simply ignore it all the time. But my advice is, besides the wetsuit, get a surfboard and surf this wave with us. So listen, thank you so much. I hope it didn't go on too long. And I hope I provoked a couple of ideas and thoughts over there that we can have a chat about.
All right, thank you so much, Arthur. Indeed, it has been a provocative talk. I was wondering, you know, we have a fellowship that we're looking at changing. It's been traditionally a cornea, anterior segment, and refractive. What would you say would be things that how we should approach transitioning to having a refractive surgery standalone fellowship? What do you think are the key elements to get that going?
So Kashif, we spent a lot of time on this. I don't know if I can answer it in the way you want me to. I don't think I can. But I'll tell you, we looked at it sort of like Carlsberg, the advert, look at a project. We said, if we could just design one, how would we design it? And the way we've thought the best way of designing it is we'd like to see a young doctor come into the refractive fellowship and say, I want to come out the other side with your skill level. I want to be as good as Dr. Bai in 2 years' time. Now, of course, you won't have all that experience, but if you want that to happen, we figure it's got to be 2 years. You've got to see people who are doing this day in, day out, how they make it work. So you're not only seeing the surgery they're doing, you're seeing the way they manage patients, you're seeing the language they use, you see the way they speak to patients, you see the consenting process, and you just see the way the whole practice works. And then you see this at many, many interfaces. You've got a host program, which might be in Toronto, but then you're doing some of your work. You might spend time with Eric Mertens for a month. You might spend time with Dan Reinstein. It doesn't matter. But you're spending time away. During that 2 years, you're doing a course called the Physician CEO, which makes a doctor think in terms of a CEO. If you're going to run your own business, how am I going to run this? And develop your leadership skills. And then it's also got a program called the Moores program, which is a didactic program on the Master of Refractive Surgery program. So at the end of that, you get a certificate from the RSA. And there's one block dedicated to IOLs. There's one block dedicated to laser vision correction or corneal surgeries. There's one block dedicated to innovation and how to work with industry. And there's a block that, put down to core competencies. And this is mostly about the way you use words, because words are crucially important for patients who are buying into a procedure and paying. So if you were to try and make that smaller, I would say what you'd want to do is have them at least see a good number of procedures where they can talk you through the procedure, and then have the opportunity to actually do a few procedures, more than a few if you can, with you watching. Now, one of the biggest challenges has always been that the refractive centers of excellence are private centers mostly, and they're normally quite reluctant to train what they see could be a potential competitor. But that's where the RSA sees things very, very differently. We don't see any other colleague as a competitor. We see them as a validator of the space we're in. And we believe that the more refractive surgeons there are, well, guess what? The more refractive surgery we're going to do. The more Starbucks cafes there were, the more people drank coffee. So we don't see others as competitors. We see them as collaborators. And the more that are doing it, the more they're validating the space. Yeah, there's a need to make people see better. So I think those are the kinds of key messages I try and get through. But getting your hands dirty, doing cases, taking responsibility for a patient, from doing the workup, making the call, running it by someone more senior, doing the surgery, and managing the complications. I think one of the key things about refractive surgery, because we have this crazy concept that it's easy and any idiot can do it, any monkey can do it, is we don't know how to manage the complications. And until we can manage complications so well that the patients no longer see them as complications. Yeah, my friend had a problem, but 6 months later it was perfect. We're not going to be able to bring it to the level it needs to be. So I think managing complications is an important part as well.
Okay, thank you. And what strategies have you found useful to educate our colleagues in ophthalmology, to kind of give them insight as to what we do? As I agree, it's an ongoing challenge.
I think, you know, mostly if you have a meeting in a conference, you would try and get the message across in some way. Channels that have worked very, very well have been the likes of the ophthalmologist or CRST. They've been really good at giving pages and exposure to refractive issues, dealing with complications and case studies and talking about refractive. So I think the only problem is these journals are read by cataract and refractive surgeons. So it doesn't really spread out beyond there. So I think we've got to try and make it more. The one meeting that you arranged, you invited me to, the CSO, there was a fabulous way of the way it was done, where 7 of the keynotes sat at the same table and then commented on one of those talks. And you were the moderator. And you asked people what they thought of different talks. I mean, you asked the other colleagues who were uveitis specialists and glaucoma specialists and strabismus, and I can't remember what else, and what they thought of my talk. They said, yeah, interesting. And when you said, well, what do you think about, do you think you'd ever have it done? And they all said, no, my glasses work fine. And then you asked me what I think of their comments. And I said, really sad, really, really sad.
I remember
you know
that.
Something, I know so much more about every one of your topics, and you know nothing about the space I'm in. And yet this is the space that changes the perception of ophthalmology. You know that if you have a glaucoma patient, his visual field shrinking down, not seeing that well, it happens to be -7. And at the earliest sign of cataract, patients 65, 70 already, you do a cataract and give them emmetropia. The glaucoma almost disappears in their mindset, because suddenly they're seeing. And for the first time, they've got this massive gain, as opposed to this continual, what have I lost all the time? And anyway, they had no idea that wearing varifocal spectacles, that most of them were, increases your risk of falling and breaking your hip. So I think it's those sort of opportunities we need to, it's provocative, but we need to make people think about it. It's not right. If our brains, if evolution has led us to a place where 65% of the hardware in your brain is dedicated to vision, the speed of processing is dedicated to vision, 10 times faster than anything else, than touch, and 100 times faster than hearing. How could we argue with the fact that being able to see is not important? And why should you wake up in the morning and not see until you put your glasses on? Or wake up at night and your baby's crying and you have to find your glasses before you can see your baby. I mean, that's crazy. In this era, when we can do this kind of thing, why is being able to see not valued more? You know, we've got a lot of work to do.
Okay. Well, thank you so much, Arthur, for a great talk. I think I'll likely be fielding a lot of questions from our trainees in the next few days to come. But thanks again for spending your time and sharing your thoughts with us. I'll let you know when the talk is available on our YouTube channel. And thank you again, and have a great night.
Hey, Kashif, it's my pleasure. Thank you. I really appreciate it. As you know, you asked the question is, we don't get that many opportunities to speak about this very topic. And it's one that, what are your colleagues in your room? They're not all in refractive surgery, are they? The four of you
are trainees, and 3 trainees and 1 optometrist here at this site, at least.
So hopefully some of you are thinking, yeah, refractive, yeah, it's interesting. It's worth looking at least. I think that's what we want to get out there, that ophthalmology is not only glaucoma and retina. There's a lot more to it. I think that's the key message.
We have one more question for you, Arthur, if you don't mind.
You know how they're taking cataract surgery globally and like doing these mini missions for cataract surgery? I think that would be much more useful to have a refractive surgery global mission. Do you think that is possible in the future, knowing how much it costs right now to do it?
Absolutely. That's exactly what we're speaking about. So imagine you can do refractive surgery camps. You've got young surgeons learning from people who've got a lot of experience. The third world patient is getting this gift that they otherwise wouldn't be able to get. Everyone wins in the scheme, and you change their lives forever. So we believe very strongly in that model, and we believe that investing in someone at 20 does in a way make a lot more sense than investing in someone at 65. Of course, we want to treat patients at 65. People are living to 85 and 90 and 95. So don't get me wrong. We don't want to take away anything our colleagues are doing that is to bring medicine to where it is right now. But all we're saying is we're leaving a lot of people behind where we can really change their lives. So that's exactly what we're thinking about. That's how we want to see this.
Global organizations are investing in getting glasses and gathering glasses and making those prescriptions and sending them over to several countries, and still they're not perfect because they're not being made for that, customized to that specific patient.
Yeah.
But so far, refractive surgery is an expensive thing for somebody who's elite, who has the means. It's not going to be available for everybody.
No.
I think the burden is big.
With industry support and doing it at a scale like this, you can make it work very effectively. What does a cataract cost in Toronto, and what does it cost in Dublin? What does it cost in India? There are ways of making it happen, and industry are happy enough to make this happen too. You know, they also want to go to bed at night, look at their share price, but also sit back and say, you know what, we made the world a better place today. We helped 100 people who couldn't see are now seeing well, and their life has changed. Their pathway forward has changed. So we've got a big jar of glasses in our clinic that people dump them in when they've had surgery, and we send them away all the time. But what happens once they get to places is they get broken and stolen and sold. People sell their glasses to get a plate of food. Whereas if you've done the surgery for them, you know, they can't sell that. They've got the vision, and now they've got a better chance at life. Awesome. Great question.
Thank you again, Arthur. Have a great night, and I look forward to seeing you in person one day soon.
Excellent. Thanks, Kishir. Thank you all. Thanks for your time. Take care. Bye-bye.